Welcome, everyone, and thank you for joining us for our 8th annual Warrior Connection. You have made a great decision to be here today, and you will see what I mean in a few minutes. I'd like to welcome not only our past Pink Aid supporters, but those of you who might not be familiar with Pink Aid and what we do. Before I introduce our special speakers, I'd like to briefly share what makes Pink Aid so special. 15 years ago, Pink Aid was founded with a simple but powerful mission to provide financial support to underserved patients undergoing breast cancer treatment. Born out of compassion and community spirit, it began with 4 civic-minded individuals, Amy Katz, Amy Gross, Renee Mendez, and Andrew Mitchell, who hoped to raise $30,000 at a luncheon at Mitchell's of Westport. Their initial goal was to fund free diagnostic testing. What happened next exceeded all expectations. Lo and behold, the town of Westport rallied. And from that local effort, Pink Aid has grown into a national charity with a second chapter on Long Island and has provided over $13 million in support since 2011. Pink Aid provides funding in 4 different ways. It supports diagnostic testing and screening, wellness and recovery, outreach and education, and essential household expenses. Simply put, it provides grant funding for things like mammograms, genetic testing, cold cap therapy, wigs, and emotional support. But that's just one arm of Pink Aid. Pink Aid also has a National Emergency Financial Assistance Program, or Pink Purse. Many of us in the room today know a breast cancer diagnosis is very stressful and worrisome. It's even more so when you don't have health insurance or sick pay and you have a family that counts on you. Through Pink Purse, we step in during women's darkest hours to keep the lights on and the food on the table, literally. And thanks to our generous donors, we cover essential household expenses like the rent, utilities, transportation, and food. And we proudly do so within 48 hours of receiving an application. Today's Warrior Connection, what we're here today for, was created as a way to give back to our supporters, past and future, because we believe knowledge is power. We want you to leave here today not only inspired, but empowered with actionable information that can help you stay healthy and maybe even help someone you love. With that said, I'd like to introduce our special guests, because we couldn't do what we do without the work of incredible surgeons and oncologists like the ones joining us today. Dr. Elisa Port, Chief of Breast Surgery at the Dubin Breast Center at Mount Sinai Hospital, is one of the country's leading experts on breast cancer care. Dr. Port is a trusted voice in the media and a sought-after speaker. She has been featured in the New York Times, NPR, CBS, Today Show, Mornings with Maria, and Pix 11. And with her surgical time in such high demand, it's a rare day you don't find her in scrubs, which is why we're especially grateful to have her with us this morning. She is joined today by our moderator, Dr. Richard Zelkowitz. He is the Regional Medical Director for Breast Medical Oncology for the Fairfield region. And most recently, he is also the Medical Director of Breast Medical Oncology for the Hartford Healthcare Cancer Institute. As many of you know, with all of these titles, he is still the doctor who will graciously share his cell phone number with his patients and pick up on the first ring whenever he can. So here's how the program is going to work this morning. There are going to be 3 main topics, each covered in about 10 minutes, followed by an open Q&A. Feel free to ask anything. You can stand up and ask your question. You can jot it down and hand it to Cindy, who will have the microphone. There's one caveat. Please, please, please do not ask a personal medical question. Not even the ones that start with, I'm asking for a friend. These two will spot you a mile away. So anyway, all kidding aside, I am now going to turn this over to our moderator, Dr. Zelkowitz.
Thank you. Thank you very much, and thank you for, again, having me back here. Dr. Port, we know each other a long time.
A long time.
We've taken care of a lot of patients, and I think the most exciting thing that we can say today is how far we've come in the years that we've known each other.
Totally agree.
So let's get to the crux of this. We have saved more lives. We have made more diagnosis. What are your recommendations for screening?
Right. Well, first of all, I want to thank Amy and Trish for inviting me and for the incredible opportunity to be here. I see so many familiar faces in the audience, friends, patients, etc. And it's such an honor to be here. And Richard and I, we were just talking about how long we've known each other. It goes back to my days at Sloan Kettering when we would gather for tumor boards. And what we developed was a real kinship and very like-minded approach to patient care.
And we won't tell you when that was.
And so I feel like we've known each other for such a long time, shared so many patients in common, and the idea that we kind of mix and match with our patient care has been such a blessing in terms of having someone up in Connecticut for patients who come in for surgery into the city and so forth. So it's been such an honor to collaborate with you and take care of people with you over the years.
Thank you.
Let's get to it. So in terms of screening, I think one of the reasons why we want to discuss this is because my point of view is this should have been over a long time ago. It was, where the recommendation for screening mammograms was starting at age 40 and every year after that for the general population. We can talk in a minute about who needs to start earlier, who, how long do you go, all those things. But that message was crystal clear for a very long period of time. And what happened is a couple of the national organizations who are somewhat charged with making these recommendations started changing their tune. And there's a lot of controversy as to why this happened. The long and the short of it is it was mostly related to cost cutting, okay, and prioritizing anxiety and false positives and cost saving over lives saved. There was no change to any of the data that suggested that, particularly between the 40 and 50-year-old group, that there isn't lives saves. We know that that's true. If you're getting mammograms every year in the 40 to 50-year-old age group, compared to not, if you develop breast cancer, you have a 15 to 20% higher chance of survival by picking it up on a mammogram. No one really ever debated that. The issue is there are some of these organizations that said, you know what, maybe that's not as important as all the anxiety these mammograms are causing by finding all of these things and then making people histrionic, the word they always use with us, right? Histrionic, we get anxious, right? No, we don't. We're big girls, we can take care of ourselves, and we can deal with the findings. And so that led to, in like 2009, the recommendations changed, and then again in 2015, American Cancer Society actually jumped on the bandwagon and changed their mammogram recommendations, and that was a huge blow. They started saying, no, maybe you don't need to start till 45, and maybe you do it every other year. You can Google this online. Myself, along with two New York breast imaging leaders, wrote an op-ed that we published in the New York Times in 2015. I was really mad because I actually attended this American Cancer Society Mother of the Year lunch honoring one of my radiology colleagues, Dr. Susan Drossman. And there was this is like total sidebar, but it's an interesting story, I think. she was being honored, and I rallied a whole group of people to come. But we got word like the week before that they were going to change. American Cancer Society was going to change their recommendations against mammograms in that age group. And Susan and I got on the phone with them, and we said, look, if you're going to do this, we're not in anymore. We can't do this. We can't be a part of it. And they were like, no, that's not going to happen, et cetera. We have the lunch. We all come out in droves to support. 3 days later, they issued their change in recommendations. So it was very devastating and very, very, it felt very like a betrayal. And so our response is she and I and one of my radiologists from the Dubin Breast Center wrote an op-ed in the New York Times. So that came out why we said why the annual mammogram is important. That was the title of the article. And boy, this is 10 years ago. We were eviscerated, okay? The comments below, of course, mostly anonymous. Of course, the breast radiologist wants them to do mammograms. Then they would have no business. Of course, the breast surgeon, as though and all we really said was that we are on the front lines of dealing with this disease. We see what happens when people get mammograms compared to when they don't. And we have no other horse in this race other than saving lives. And if you want to prioritize that, that's what we should be doing. The data hasn't changed. So flash forward to now, okay, a year ago, the US Prevention Service Task Force actually rescinded those recommendations, and they did it a lot, partly because of the fact that we know that younger women, particularly Black women, do get breast cancer younger and often more aggressive. And so in response to new studies showing that, they backed off and said, yes, maybe it's okay to start at 40, what we knew all along. What they didn't go far enough to do is go back to every year, which is what we need, which to me, as a person, this makes no sense to me. If you're saying you want to start doing mammograms earlier at 40 because younger women, especially Black women, get more aggressive breast cancer, why would you do that test every 2 years?
Especially in that population.
In that population, okay? So a lot of the questions were about triple negative breast cancer. Black women get a lot of triple negative breast cancer. We can talk about that in a minute, but that makes no sense. If you're doing it for one reason, don't talk out of both sides of your mouth, right? So, we stand strong that it's mammograms every year, okay, starting at age 40. When do you add ultrasounds? Well, it started here in Connecticut, guys, the breast density notification.
Jody Rowe.
Yeah, the breast density notification law saying if you have dense breasts, you need to be told, because dense breasts are one reason why things fall through the cracks on mammograms. I always say mammograms are really good, but they're not perfect. They pick up about 85 to 90% of breast cancers. In dense breasts, it's lower than that. So how do we close that gap? And ultrasounds can help a lot. So if you have dense breasts, ask about ultrasounds. And the last two things I want to talk about related to screening are MRIs, okay? That's a huge area of controversy. When do you get them? We typically reserve MRIs for our patients at the highest risk for breast cancer. So if your risk is above 20% or so, where the average woman's risk is 10 to 12%, you are then eligible for MRI screening. How do you get to that 20% number? It's usually based on family history or having had a biopsy that shows some funky looking results like atypia or something like that. That's really the way you get there. And so every woman should have a clear understanding of what her risk is, and based on that information, decide with her doctor whether adding MRI is helpful. We don't want to do MRIs on everyone because A, they are expensive, B, there's a dye involved. And there is some controversy over whether or not years and years and years of the dye, getting them every year, some people say it can accumulate in the brain, and perhaps it can cause adverse effects and so forth. I really have very little worry about it, but I think that it's something to talk about, whether or not you are going to be screened every year with MRI. And also with MRIs, there are what we call false positives. If you get an MRI, there's a 10 to 20% chance we'll find something, Only a small number of those are cancers, so it can take you down that rabbit hole. And so you've got to just be prepared and have an educated conversation with your doctor about risks and benefits. Last thing I'll bring up, because it was in the news recently, and I just think that, to Richard's point, there's new things in breast cancer every year. That's a good thing. But a lot of information can be overwhelming, and it comes with a huge amount of misinformation. Contrast-enhanced mammography. There was an article in the New York Times. It is a really good tool to pick up cancers that regular mammograms miss. But I view it as kind of a poor man's MRI. And I don't mean money. Like, it's the cheaper version of that. It does involve contrast. That contrast can provoke allergic reactions and so forth. And so my feeling is, for most people, if you're at high risk, you really should be getting the MRI, and then the contrast-enhanced mammogram doesn't really add much. It is a screening test. Lots of people just don't want the contrast and don't want what goes with that. Just like a lot of people have allergies, it's the same contrast as what you get in like a CAT scan and so forth. It's not the same contrast that you get with an MRI, which is gadolinium, very different. So those I think are the basics of screening. I'd love for Richard to comment on the fact that, one of the things is that if you don't screen, you're at much higher risk. We can still cure you, but you are at much higher risk of not being cured, number one, and number two, needing more treatment to get there.
Yeah, I mean, the first point I was making is there is something called interval cancers. And that's why doing it every other year, especially in the younger patient, the young African-American patient, doesn't make sense. I think the take-home here is if you go home with nothing else, your risk of getting breast cancer is being a woman, and your risk of getting breast cancer as you get older. And all the other stuff is kind of comes with the territory. So there is nobody who says to me, well, I'm 42, but I have no family history. I'll drive you. You need a mammogram. So as far as MRI, I also think what's exciting about MRI is we're evolving, and MRIs are getting quicker. And so the ordeal of the MRI has become less so. So now we have shorter interval for the MRI. And all these things are really, really important. We know that the earlier you're diagnosed, the better your prognosis is. In all likelihood, the less treatment you're going to need. We'll talk about that in a little bit. So the take home again, get your MRI, get it at 40, and do it every year. So genetics. Genetics is particularly exciting.
Yep. Huge, yeah.
When I started, there was no genetics, right? In the 1990s, we had BRCA mutations that were identified.
94 and 95.
94, 95, and we've evolved there. What are your feelings about genetic testing in patients?
Yeah, so look, genetic testing is, again, knowledge is power. And genetic testing is one of those areas where finding out that you are genetically predisposed is game-changing information about health. And there is stuff you can do about it. So, well, yes, it can be very, very upsetting to someone to learn that they're a genetic mutation carrier. What I turn around and say to people is, let's start destigmatizing this, okay? Any of us who are parents or children, and we all are children, we all inherit stuff from our parents, okay? We all pass down things to our children. There are things far worse than the BRCA gene. There's heart disease, there's schizophrenia, there's mental health issues, there's all kinds of things are genetic, okay? BRCA is just one of them. And finding out that you have something that you can actually do something about, reduce your risk of getting breast cancer, reduce your risk of getting ovarian cancer is extremely empowering. So as Richard said, genetic testing became very mainstream in my first years of practice. And in those days, we were just testing for two genes, BRCA1 and BRCA2. They're the most well-described genes related to breast cancer risk. They're also associated with the highest quantifiable risk of getting breast cancer. We estimate that if you have a BRCA1 or a BRCA2 mutation, your risk of getting breast cancer is probably somewhere between 60 and 90% over your lifetime. And also, extremely importantly, Richard just pointed out, what are the risks of breast cancer in general? Being a woman and age. To his point about age, what is the average age that a woman gets breast cancer? Well, we just had our Dubin Breast Center fact versus fiction lunch. We asked a question when everybody walked in. True or false? The average age of a woman getting breast cancer in the United States is 60 years old. 90% of people said false, okay? It's true. In this country, the average age of women getting breast cancer is between 60 and 70, okay? Now, many of us know groups of women who get it much earlier, and in populations of people where the BRCA gene is much higher, that is what you will see. Because not only does BRCA increase your risk of getting breast cancer, it increases your risk of getting it early, and you're at risk in your 30s and 40s especially, okay? So risk of getting breast cancer, risk of getting it early, risk of getting ovarian cancer, which I always say, regardless of what you decide to do as a BRCA mutation carrier about your breasts, getting your ovaries out at around age 40 is life-saving. Life-saving, okay? Even if you decide to screen your breasts, even if you decide, there is no mammogram for the ovaries, okay? There is no early detection for ovarian cancer. There's lots of people who say they're so good at it. I have one radiologist in the city who it feels like she could crawl up inside you and feel your ovaries, okay? It doesn't work that way. There's absolutely no early detection of ovarian cancer. There's this blood test called CA-125. It's normal in 50% of women with stage 1 ovarian cancer. It's not good. So we do these stupid tests because it makes people feel like they're getting something, but it's not effective. The only effective thing is getting the ovaries out as a BRCA mutation carrier around age 40. Even though I'm a breast cancer person and I try to stay in my lane, to me, identifying someone as a BRCA mutation carrier, these are the ways, some of the other ways we save lives. So it's super important. To Richard's point, we've added to the BRCA spectrum. Now there's about 8 or 9 other breast cancer genes that we can test for. There's CHEK2, there's ATM, there's BRIP1, there's all kinds of other PAL-B2, and these all are associated with different risks and degrees of getting breast cancer. I saw a CHEK2 mutation carrier in my office earlier this week. Her risk of getting breast cancer is somewhere between the 20 to 40% range, not 60 to 90%. So there's no one size fits all here. And what's interesting about BRCA is your risk at that high level. It doesn't matter who in your family has or has not gotten it. With some of the other genes, your risk can be more related to who in your family has gotten it, the actual disease. That's what's called penetrance of the gene. So that's important to know too. What I always like to say is that, getting the information does not force anybody to do anything. We do not come to your house and say, your number's up, right? It's information, and we can increase screening and improve your chances that if you develop cancer, we've picked it up early. I'd like to just hand it over to Dr. Zelkowitz, because I think what's super exciting in the new and everything is that finding out that you're a gene mutation carrier also has huge therapeutic implications for how we treat breast cancer.
So just to expand on that, this is another example of knowledge is power, and what you do with that knowledge is super important. And that knowledge that you get from genetic testing, and genetic testing has to be interpreted by somebody who understands genetic testing, because there can be misunderstandings. But genetic testing allows you to also inform your family and inform your children, and inform your relatives as how to be screened. We're coming a long way in potentially eliminating some of these genes for ongoing, progeny. So this information is incredibly, incredibly helpful. As far as what you were referring to, we have drugs, particularly for the BRCA mutation, called PARP inhibitors. And they have initially been used in patients with advanced disease with really good success. And now we're using these drugs earlier on in patients who have early stage breast cancer, who we will cure and enhance that cure rate by incorporating PARP inhibitors. So again, another area where information is power, and the whole concept of too much information is overwhelming makes no sense. We agree on that.
We totally agree on that.
Totally agree on that. So what also is very popular in the news now is artificial intelligence. And I asked one of my radiology colleagues what his thoughts were on my way over here, but let's see what you say, and I suspect it will be very similar.
Yeah, I mean, look, there are certain areas of medicine that AI is going to blow it out, okay? I'm very grateful that the computer has not yet grown a pair of arms, so I'm in no danger really of being replaced anytime soon. Yes, there is robotic surgery. That it's not in breast yet, so I'm still okay, but I'm happy to take early retirement. Rich and I were just talking about, we've done enough. I think it's okay. But as long as there's stuff for us to do, we're happy to do it and help. Here are the areas where we think AI is going to be very, very big and is already. It's a lot of stuff where it involves reading studies. So radiology and pathology, okay? These are things where computer learning can teach patterns and can help in interpretation of results. So just to give you an idea, there's three really, really exciting things, one of which I'm not sure I'm allowed to talk about, but I will anyway. Right
Connecticut,
now,
you're fine.
Yeah, whatever. It seems like a safe crowd. Imaging, mammograms. Right now, at the Dubin Breast Center and at Mount Sinai in the health system, every single mammogram, every single one, is double read by AI. So we have a human, and then we have the AI, okay, for free. Okay. There are definitely places where they charge for the added AI. I think it's like $500 or something. We do it for free, okay? And what I turn around and say is, look, the data is not clear yet, but humans do make mistakes. And why not have an added layer of support? And so I feel very good about this. And you can train these computers after looking at hundreds of thousands and millions of mammograms to understand patterns, okay? There's a new technology that everyone is very excited about that says, you know how we were talking about before figuring out risk for breast cancer? So, we know family history is a risk. We know that having prior biopsies is a risk. We know that not having children is a risk. Breastfeeding is favorable, all these things. Well, what if someone could throw all of those risk factors out and all that interpretation and just figure out your risk of getting breast cancer just by looking at your mammogram? Okay, that would be crazy, but it's happening. Okay, so those are other things. There's some new, FDA-approved technology that will probably be doing that. They don't care about your family history. They don't care, and a lot of it is because of what Richard said. 90% of women who get breast cancer have no family history. So they think they're not at risk. They don't get mammograms, but they get breast cancer. They are their family history. So that's really important. The other thing, the part that I don't know if I'm supposed to talk about, but I will, is that one of the things as it goes by imaging is, I'm very excited about, is that we're starting this at Mount Sinai, this collaboration with an Israeli company. As you know, BRCA mutation carriers are very, very heavily weighted toward the Ashkenazi Jewish population. To give you an idea, if you take 400 women of mixed descent, one of them will be a BRCA mutation carrier. If you take the same group and it's Ashkenazi Jews, 10 will be. So it's 1 in 40. So 2% of people that are of Ashkenazi European Jewish descent will have a BRCA mutation. Are other groups vulnerable too? Of course. We've all seen BRCA mutation carriers in Black women, in Hispanic women, in Icelandic women, in Swedish women, et cetera. So there's no group that's off the hook, but that's the group where there's a preponderance of this. Well, you find a lot of Ashkenazi Jewish women in New York City and also in Israel. They have a huge population there, as you can imagine, and they're very, very invested in screening among BRCA mutation carriers. So, and they're very good at AI, it turns out. So we're working together to, believe it or not, come up with an idea that, imagine if you took every single BRCA mutation carrier that is getting yearly MRIs, and then at some point, some of them will develop breast cancer, right? So imagine you take their MRI where they have breast cancer, and you take the 3 prior MRIs before that, and see if you can, like the human identified it here, but I wonder if the machine could have identified it here or here. So they have this wealth of data, right, of MRIs, 10 years of MRIs in people leading up to when they got breast cancer. And we have the same thing at Mount Sinai. And so we're pulling data and trying to explore whether or not we can detect breast cancer earlier than early detection. And they've written about this. They're the leaders in this field, and we're excited to collaborate with them and that is one way that AI can be very, very instrumental.
By the same token, the AI does not have a heart. And so we're going to still be needed because you still need to look at the patient.
Yes, of course. The other area where AI is going to, I think, really have an impact is in pathology, diagnoses. Breast pathology is a very complicated field. We say you need to have expertise in that. One person's atypical cells, like could be another person's early cancer, DCIS. We did a study at Mount Sinai where people who came in with outside slides, how often we upgraded them to cancer or downgraded them, saying that you don't have cancer, is about 10%. So standardizing this, because remember, we live here in Connecticut and New York where there's tons of breast cancer experts, people like us who devote our life to that. But that's not true of everywhere in the country. And there are underserved populations, and there is no breast pathologist in rural Kentucky, okay, who they can't make their living that way doing only breast. So how do you provide better care and extend the access? That's how you do it, by developing these technologies.
And be able to review more cases and more slides and whatnot by automating it. So
I mean, Richard, how do you see AI figuring into the medical oncology world?
So it's a perfect setup because there was a paper in Journal of Clinical Oncology, which is my go-to journal, which talked about ChatGPT and interpreting tumor boards. And I think the point is that we continue to make progress. And this is our future. We're not there yet. We have still seen significant discrepancies about what the computer generates for a recommendation and what the patient is. But unquestionably, they will be able to make things much better for us and help us make much better and much more precise decisions and recommendations for patients. Let's go in a different direction.
Okay.
All right, because I'm getting the fingers and the signs here from
Hopefully
my wife.
not one
I don't even
specific
know what that
finger.
means. As my fly open, I'm
Hopefully
all
this
I'm
finger,
comfortable
right?
about
This
this.
finger.
So after 38 years, I know all the signs.
You know all the fingers? We all know all the fingers.
So, when I came to Connecticut in '90, and I have a very young wife, so it's a long time ago, I came to Connecticut as a transplanter, and I had trained, and I went to a place called the Hutch where we did bone marrow transplants, and we did bone marrow we believed in those days bone marrow transplants for non-leukemia kind of disorders, because the concept was if a little bit was good, a lot was better. We say that a lot in Fairfield County. And I think what we are now learning is instead of looking for the maximum tolerable dose for people and the maximum effect we could put in, perhaps we need to look at the minimal effective dose. And I sat there in the early 90s and listened to them argue about how mastectomy was the standard of care for all patients, and clearly they were wrong. So I don't know that anybody made a bigger impact than the surgeons right from the get-go as far as that.
I mean, I think, the long and the short of it is the word that Richard is talking about is the theme is called de-escalation.
Right.
Okay? De-escalation of treatment. We all learned, as Rich said, we have so many amazing treatments that work. The cure rate for breast cancer is now what? 91%. So we're doing really well. I was recently at our meeting is the American Society of Breast Surgeons, and I posted this on Instagram. Someone put a slide up. It was so cool. And there were people who were literally tearing up in the audience. It said the goal is 0 breast cancer deaths by 2030. 0, okay? And when you're at 91%, that goal isn't very far away, right?
Yep.
But the big question is, so we've got all these treatments out there that work. How do we figure out to take more of a, instead of a carpet bomb approach, how do we use more of a precision approach? And to Richard's point, this has happened a lot on the surgical front and a lot on the oncology front, and he'll talk about that, which is how do we dial back or peel back treatment without compromising cure and effectiveness of our results. And so the surgical examples, and I'll give 3 short ones, is mastectomy versus lumpectomy, as he brought up, is one of them. Up until the 1980s, right, the only treatment that was offered was mastectomy. Part of that, remember, was because most women needed that because there was no screening, and so we were finding these cancers when they were very large. And even if they were picked up early, they really were large, and you really couldn't do a lumpectomy and get all the cancer out. Flash forward to as mammograms started taking hold in more of a widespread way, we were finding cancer smaller and smaller. So a lot of very smart people, a lot in Italy, a lot in this country, a lot of different countries said, I wonder if we can do smaller surgery for this 1 centimeter cancer. Why does the whole breast need to come off? And so the randomized trials that were done in the 80s showed that if you did a lumpectomy and added radiation to it, your survival rate was the same as a mastectomy. And so that was the huge example now, almost 50 years ago, of de-escalation. The second big theme of de-escalation came with lymph nodes under the arm, which was huge, okay? Prior to...
And you were at the forefront of that.
We were. We
were
used together.
to send our Connecticut patients to you guys to do
sentinel
sentinel nodes.
node. Right. So the usual way to check lymph nodes before the mid-90s was you make a big cut and you take them all out, okay? And that's a really big operation. Most people know it's associated with a lot of potential for lymphedema is the most dreaded one, but also numbness and range of motion issues and all of these other things. And we'd be standing in the office a week after surgery with our pathology report saying, good news, Mrs. Jones, I took out 20 lymph nodes and they were all normal, okay? The problem is that's great news from a cancer standpoint, but you can't put them back, right? And remember, again, to Richard's point, in those days, a lot of women did have positive nodes. So we were doing that surgery a lot out of necessity. As we started picking up cancer smaller and smaller, the likelihood of a 1 centimeter cancer spreading the lymph nodes is 10%. So imagine taking out all of your lymph nodes in every single person. Now 90% of people are having more surgery than they need and are going to suffer those consequences. So, but the big question is, could we figure out who did and who did not? And so sentinel node biopsy, which I'm sure many people know about in the audience and a few have even had, involves injection of some dye into the breast, and it migrates to a couple of the nodes under the arm. You remember under the arm we have 20, 30, 40 lymph nodes, so it goes to 2 or 3. And we can as surgeons now pick out just the lymph nodes that we want for checking. And then if those have cancer, we may or may not go back in to take more. But the net effect has been sparing so many women that more extensive surgery. The newest kind of development on this front, literally I'm talking about in the last year, and we grapple with this every day now, is a trial that came out a year and a half ago, 2023, sound trial? Yeah, the sound trial, an Italian trial that was done, where they took all the women that I talked about, really small cancers, really favorable profiles, not the triple negatives, not the HER2 positives, but the ones that were ER/PR positive, HER2 negative. Typically, they did it in a very large age group of people, but they were mostly older, and they did sonograms, ultrasounds of the armpit lymph nodes before surgery. If that ultrasound was normal They didn't take out any nodes. So they did a lumpectomy, took out the cancer, no axillary surgery, no axillary dissection, no sentinel node, nothing. And when they followed those patients, I think it was 5-year follow-up, there was no difference in recurrence rates between the people who had their nodes checked and those who did not. It was about 1 or 2%. Okay? And people say, well, how is that possible? When the people who had nodes removed, about 10% of them had positive nodes. So you'd assume 10% in the other group who had no nodes removed also had that. So what happened to that disease? The answer is remember, thanks to Richard and our radiation oncology colleagues. I know I'm not supposed to call you Richard, right?
Every time you say it, I sit up straight and I look for my mother. So,
don't look here. Okay. Richie, thanks to Richie and the treatments he gives and my radiation oncology colleagues, they do give other treatments that can mop up microscopic disease. So this was a landmark trial, and now when women come into my office, literally for the last year, that's an added layer of conversation saying, you know, you're eligible to not have your nodes checked at all. Do you want to do that? Here's what the risks are, here's what the benefits are. So this is a perfect example of de-escalation. And I think I want Richard to talk about the chemo part, because that's like way more important, I think, relative to overall patient well-being, you know, the inroads. But what I will say is one thing. I know I'm preaching to the choir in this audience, but you will read out there a lot of stuff about, like I said, with this editorial I wrote, of course surgeons want to do more surgery. Of course oncologists want to give more chemo. Of course, you know, we have a vested interest in people still getting cancer and curing cancer because that's how we make our living. Surgeons are leading the charge to do less surgery. Radiation doctors are leading the charge in the studies to scale back radiation. And medical oncologists are the ones doing the work to figure out if no chemo is needed, okay? We are the ones doing this work. No one's doing it for us. And so for the public conspiracy theorists who are like, no, you know, President Nixon declared a war on cancer in 1970 and it would be cured if everybody was on board, but the doctors are trying to, you know, they need something to do. We don't need more to do, right. And we're leading this charge. So talk about this stuff on the chemo front. Yeah.
But one other point. A decision like that, though, needs to be made with somebody with Dr. Port's expertise. Dr. Port can look at the specific situation, and it should not be extrapolated broadly. You need to really know the facts, and that speaks to the expertise that you bring to the table as the surgeon, because we don't want people who do need their nodes to be removed, not be for the wrong interpretation. As far as
it impacts what you decide to do.
Absolutely. As far as de-escalation in my world, again, I won't tell you what year I went into practice, 1989, but at 1989, if your tumor was a centimeter, or a sonometer, I guess that's how you say it in Connecticut, you got chemotherapy. It didn't matter, anything else. Size mattered. It was all about the size of the tumor. And we talked about genetics, and genetics is the X that you got from your mom and the X that you got from your dad, or Y in my case. Genomics is, we can look at your tumor now. We can do tests in a huge population of patients, the hormone-sensitive patients, and we have reduced the use of chemotherapy by 30 to 40%. We have a much better understanding of the biology of this disease. Less is best. Everybody does not need chemotherapy. It doesn't help a good percentage of patients. And that was a huge change. And as time has gone on, we've been able to enhance this technology where we look at the genomics of tumors, and there are things like Oncotype and Mammoprint and P50, and I'm sure there's another one that I'm forgetting, and really understand the biology for patients and say, you don't need chemotherapy. You need this, and you need that, and you need the other thing. The next area where it has become huge is, as in the course of my career, we identified something called the HER2 protein in breast cancer. We didn't know about HER2 protein in 1990. We identified it. It was initially a very difficult tumor to treat. We identified a medicine called Herceptin. We identified a way to approach those with aggressive chemotherapy. Well, we just came back 2 weeks ago from ASCO, American Society of Clinical Oncology, and again we found we can de-escalate the chemotherapy. That's huge. Less is best. So that's another place that we have really de-escalated it. And now you're reading about less hormone therapy. We're going to, again, get back to the concept of instead of maximum tolerable dose, minimum effective dose. We have some data for something called baby tamoxifen. Baby tamoxifen is a lower dose of tamoxifen. We now have data for non-invasive breast cancer. There is a trial looking at it in invasive cancer. We're getting better, and again, less is best. So that's the biggest areas that I could think of in my world. And the radiation oncologist, and again, I'm not a radiation oncologist, but they're doing less, and they're not radiating everybody, and the duration of radiation is shorter, and the focus of radiation is shorter. So we've come a really long way, and in the process of doing less, cured more patients. So it's something that I'm very proud to say. When I started in oncology, we had tamoxifen, 4 chemotherapies, and no CAT scans. we got 30 new drugs this year. So
There's some statistic that in the last 10 years, there have been more effective drugs developed for breast cancer than in the prior 30 years combined. So,
we're going too long. All right,
So
we're going to
that's-
very quickly,
Yeah.
last topic, okay, because
Okay.
I think this is very important.
Okay.
Okay, lifestyle modifications
Yes.
and your risk of breast cancer.
yeah,
Anybody
Yeah.
in this audience who's my patient knows WWW. Walk, wait, and wine. Drink less, walk more,
I like that. I'm stealing that for my new book.
no problem. Walk, wait, and wine. So exercise, reduce your weight,
Yeah.
and drink less.
Yep. Yeah. I mean, I have very little to add to that, but I'll figure out some way to yes. You know, the two main, everyone, you know, and this is also one of the areas, Rich, where I think the treasure trove of misinformation out there. You know, when you're diagnosed with breast cancer, especially for the people who don't have a family history, which, as we already talked about, is most people, 90%, there's so much, at first, self-flagellation. Why is this happening to me? What did I do wrong? I grew up near a toxic waste dump. I ate too much this. I didn't drink enough that. I didn't have enough green juice. I ate too many French fries. I mean, there is a bottomless pit of reasons women pull up, dredge up, to assign self-blame and self-fault, okay? And there's no role for that, okay? So there are two lifestyle factors that we come back to, and because I lump walk and weight together, because yes,
It's not working that well for me. I'm walking a lot.
The walking part, the exercise part, yes, that is independently important, but it's mostly important as it funnels into weight. You know, recently I had a patient who came in and she had a lumpectomy and had a sentinel node. She's about 45. And I said, listen, she goes, anything I shouldn't do after surgery? I was like, give me about 4 or 5 days with no exercise, like no heavy lifting. She goes, that's okay, I don't exercise. I said, at all? She's tall and she's thin and she's beautiful. I said, she goes, no, not at all. I'm like, yeah, I've never seen that before. A tall, thin, healthy woman who doesn't exercise at all. I'm like, okay, that's a new one for me. In general, the walking is mostly, most women who maintain a healthy body weight do have exercise as a regular component of their lifestyle. The guidelines, just to give you guys, again, actionable items, we say, you know, the most of the guidelines are at least 5 hours a week, so that means something almost every single day. I say more. And at least 2 or 3 of those hours should be vigorous. Like, I get it, walking, it's a big thing to do around here. running, get in the pool, really get your heart rate up. I think walking up a hill is probably better. So I think, cardio is really, really important. And I think that's part. The weight-bearing stuff is super important to protect against osteoporosis and so forth. And as we all know, some of the medications that are indicated for breast cancer can increase the risk of osteoporosis, so combating that. And so the two main lifestyle factors that a person can activate to reduce their risk of either getting breast cancer or recurring are weight, maintaining a healthy body weight, and alcohol consumption. The weight first. This is a very, very touchy issue. Today everyone's perfect just the way they are. Okay, everybody's body image, you just self-love no matter what. Okay, I'm here to tell you that there is a point where weight crosses over to being unhealthy. If you are on a medication because of your weight that you would not be on if you weren't the weight that you are, a cholesterol medication, a borderline diabetes medication, a blood pressure medication, a heart medication, an antidepressant. If you are on any of these medications that if you lost fill in the blank pounds, you wouldn't need or wouldn't be on, the weight is affecting your health. That's all there is to it. Okay, that's the definition. Okay, and there's a huge range there.
It doesn't mean that if you lose weight, you can make all those problems go away.
That's true.
Right.
Yeah, but if you are, that's right. I mean, there are people who congenitally have a cholesterol problem that they'll never get off of. But what I was meaning is that if you were on those medications that if you lost the weight, you would safely get off of, you've crossed over.
Yep.
Right?
I agree completely.
So those are the things that I say, and I'm not putting a number on it because I don't want to be canceled, and I don't want to be yelled at by any groups, but that's really the definition, okay? And so weight is an important one, and I say to people, look, if you come in with a breast cancer diagnosis and you are overweight or obese, right? Patients need to fill out paperwork in our operating room that if they're obese, they sign a special waiver that they understand increased risks of surgery, anesthesia, blood clots, all these kinds of infection. These are all real. You can't wish that away, right? Those are real risks. And so if I tell people that if they're diagnosed with breast cancer, it's a little sadistic to hit them with that when they're being diagnosed and dealing with one of the hardest times. But it is a teachable moment. And so my husband is a lung cancer surgeon. He's a thoracic surgeon at Cornell. And they have a smoking cessation program for the people who are diagnosed who are still walking to their office, like having had a cigarette in the parking lot before they came into his office. If you are a lung cancer surgeon and you don't provide a patient with infrastructure and resources to stop smoking, that's unconscionable, right? And I say the same is true for breast cancer. If you walk into surgery overweight or obese, and we know that is a risk factor for recurrence, okay, and we don't provide you with resources, infrastructure to lose that weight, we're not doing our jobs.
Yeah.
And it's a teachable moment. In terms of the alcohol, I'll just say one thing, and that is that so recently data came out. We used to say in moderation it was okay. Moderation, the definition is 3 to 5 a week. Means you're not drinking every day. You can have 2 on a Saturday night, but then none for the next 3 days, etc. I know that all went to hell in a handbag during COVID for everybody, but we're done with that. And so the newest data suggests that, and so we used to say pretty regularly, in moderation everything's fine. We do now have clear-cut data that a lot is worse than a little, and a little is worse than none. So what I say to patients is, look, if you are that kind of person that says, I need to do everything I can that's in my power to reduce the risk of this coming back, by a fraction of a percentage point, you will reduce your risk by not drinking at all. To me, that's not my philosophy as a doctor or as a human being for myself. And so I do think that having a drink as a part of your lifestyle or a celebration or whatever is completely fine. And I think it's just a choice that people need to make on their own. I do think, again, that if you have an alcohol problem, or if you're drinking, a lot of people say, yeah, I don't have a problem, I just have a glass of wine with dinner every night. And usually, if you think about it, a glass of wine with dinner every night, that's called a habit. And usually, if you're having a glass of wine with dinner every night, you're also going out on a Saturday, or that turns into a cocktail and a glass of wine for many people. Take whatever you want from this. The point is that if you're drinking every night, you're usually ending up at 7 to 10 a week, okay? And that definitely is a different number than 3 to 5 a week.
Incredibly well said.
Yeah, and so I just say, take stock if you're drinking a lot or in that range. It's a teachable moment. Richard, what do you tell your patients who are on chemo and everything,
Chemo is kind of easy because most people getting chemo are not real anxious to drink. And although we've gotten better, and again, exactly as you said, moderation is better than excess. And
but what about related to the weight? I know that a lot of the, people do worry during chemo about weight gain. It's ironic. Everyone thinks people lose weight during chemo. No, in breast cancer they can gain weight, and the sedentary stuff. How do you
we try to
work
keep
with them?
we try to keep people walking. We do realize that chemotherapy is a very cyclic process where it's very hard to maintain an exercise program, and we give you steroids and they gain weight and all kinds of things. And we kind of give you a little bit of a pass during chemotherapy, and then we kind of come back at you with a little bit of a vengeance. and you're going to start seeing more and more data about helping people lose weight and safety data in that situation. And there's a trial that's looking at one of the GLP drugs in conjunction with hormone therapy. So it's not so much how much much what you eat, it's how much you eat. And we do want you to lose weight, and we want you to drink less. And I think when your kid gets engaged, you have a cocktail, but otherwise you probably don't want to do that every night. That was our kid, right? Yeah. Okay. So thank you very, very much. Do we have time for questions? Did we talk too much? Do we do?
Yes. Perfect.
Does that work for you?
Of course.
Thank you.
Yeah. Of course.
Cindy, you have the honors?
I have to be in the hour at 1:30, so let's do 10 minutes or 15 minutes.
Got it. And then I have a patient at 1 o'clock, so
Right there.
we got it.
Perfect. We're on the same page.
I'm a little closer.
Okay, hi. We have some questions that people submitted online when they registered, so I want to go through some of those. So you talked about screening guidelines for the general population. Could you talk about screening guidelines when there's a family history of breast cancer, non-BRCA, and BRCA?
Yeah, so the recommendations, thank you. It's a great question. I'm so glad we got to take a deeper dive into that. For BRCA, the recommendations are very clear. For a known or, suspected BRCA mutation carrier. Why do I say suspected? Because there are people who feel like their mother is BRCA positive, they're 26 years old, they don't feel ready to be tested to know. That's okay, but err on the side of caution and screen them like they're BRCA positive until you know for sure they're not. The general guidelines are MRI starting at age 25, and then adding a mammogram at age 30 every year. And that's really it. And you do them, no one knows if doing them together or splitting them up. Most people, for psychological reasons, like to split them up.
I like to split.
Yeah, so you're getting an MRI once a year, say in January, and a mammogram once a year in July. And you can continue on that cycle until, God forbid, the shoe drops, right? For women who have a family history but no BRCA, we typically say we recommend starting to screen about 10 years younger than when the youngest relative was diagnosed, but not before 25. So if my mother was diagnosed with breast cancer at 47, I might start at 37. And then obviously it's not only mammogram, but it's discussion of adding sono and MRI on a case-by-case basis.
And I would also add that even though I'm only one of 3 men in the room, you get genes from your father's side. So please be aware of what happened with your grandparents or your family history on the other side, because that may impact your decision to do genetic testing or be rendered or felt to be higher risk.
Okay, we have another question. Is there a time limit that is safe to keep breast implants in, even when doing a mammogram every year?
Yeah, breast implants are not unsafe. I've taken many of my friends to appointments to get them. They're not unsafe. There's no expiration date. So yes, you need an MRI every 3 to 5 years to check for the integrity of the implant. They don't hide breast cancer. There's no breast cancer behind them. You do need additional views when you're getting a mammogram to kind of get around the implant. But I don't have a problem with them at all, for people who want them, and they're not risky. There has been a lot of controversy. Obviously, the textured implants have been what's called recalled. There's a huge misconception about what that means. That means take them off the shelf. It doesn't necessarily mean take them out of your body. The risk of getting a lymphoma related to those implants is about 1 in 3,000. It's certainly, some people say 1 in 300. It's less than 1%. And so there are people who can't live with that risk and they get them exchanged, and that's fine. But I think that overall they're, no one is really sure yet what the mechanism is behind that. And I'll take it one step further, which is there also seems to be maybe a clustering based on a surgeon or a technique. I can tell you, when I was at Sloan Kettering for 11 years, and then I moved to Sinai, I've been doing this for more than 26, 27 years. I haven't seen a single case in one of my patients, and we were one of the biggest users of the textured, both at Mount Sinai early on, and at Sloan Kettering and at Mount Sinai. So I don't understand why I haven't seen them. I know there are certain plastic surgeons who feel that they have a disproportionate number of these cases, and it may be something related to what they did.
One more question. We'll pass on the microphone. What are the guidelines for monitoring breast health for retained breast tissue post-mastectomy?
Oh gosh, that's a real loaded issue, okay? Because what I say is, when you have a bilateral mastectomy, the goal should be, you're 100% right, we don't call them prophylactic, we call them risk reducing. But that risk reduction should be on the order of 98, 99%, right. Okay? And so when you do this right, that's what the risk should be, okay? That said, I think there are very, very different technical approaches where, yes, more breast tissue is left behind. I hope it's not intentionally, but based on what I've seen, it's hard for me to imagine that isn't the case. My personal feeling is when you do it to that degree, 1 to 2%, there is no recommendation for imaging or surveillance other than physical examination. Right. I think if you see a surgeon and you ask that surgeon, what will my imaging be after my bilateral mastectomy? And they say, you still need mammograms or you still need MRIs, that is a red flag right. to run away.
Right, you're in the wrong office.
You're in the wrong office. Right. I can tell you, I saw a patient I've seen 3 in the last year, 3, last 6 months, who have all developed cancer after a bilateral mastectomy, okay? 3. One of them, very, very reputable surgeon in New York, did the surgery. The woman is 90 pounds dripping wet. She might have had 2 breast cells left behind and got terribly unlucky, and one of them formed a cancer. And this woman called me and said, I can't believe, I was like, I can't either. This is exactly how I do the surgery. She's the 1%. The other 2 that I saw, I looked at them and like, this is not how I do the operation. I didn't tell them that, and the amount of breast tissue that I removed at their redo mastectomy was in the order of hundreds of grams. So I think that, and by the way, I'm so glad you brought this up, because some of this, just so you know, you guys, is patient pressure. New York and Connecticut are really, really competitive environments. If you are obsessed with your aesthetics and you're obsessed with this, if you shop around enough, you will find someone who does exactly what you want and tells you exactly what you want to hear. You got cancer coming out of your nipple? Fine, no problem. You can have a nipple-sparing mastectomy. I had a patient walk into my office, 36 years old, with calcifications going up to the nipple, who was told at another hospital she could save her nipple. I'm like, am I missing something? This is like not mysterious. I showed her the picture. I'm like, do you see that and do you see that? This is so the point is that people do what they want. And there's a lot of patient pressure, because why wouldn't you go to a doctor that promises you, yes, I can make the cut under here even though your cancer is up here, and yes, I can save the nipple, and yes, I can get all the tissue out, and yes, by the way, you can go direct to implant. Well, why would someone come to me if this other doctor is checking all the boxes that they want? Because there's not an understanding that those things are competing goals, and you can't accomplish all of those things, and what's going to end up paying the price is the breast tissue left behind. So.
Any other questions?
Hi, thank you so much. How often should genetic testing be done be repeated?
It's a great question. So most of the new genes that we've discovered have been post-2013. So we're basically telling people, look, if you were tested after 2013 and for whatever reason they didn't do a full panel, go back and do that, right?
Exactly.
Is that what you tell people?
That is exactly what we're telling people.
And then pre-2013, you should be tested again.
Right.
You know?
So most people had initial BRCA1, BRCA2, and then there was a third mutation.
Mm-hmm.
So most, at this point, if you haven't had a panel, that should be done.
Thank you.
Some of the major cancer hospitals, like Sloan Kettering, seem to be pushing the contrast-enhanced mammogram. Is that for cost? Is,
No,
is it institution-wise or surgeon-wise?
Do you want me to talk about it? Okay, yeah. So, it's really interesting. It's a great question. No, Sloan Kettering or any institution would never do that, I don't think, for cost at all. I think, about 10, 15 years ago, there were two really new technologies, 3D mammography and contrast enhanced. And different institutions kind of put all their eggs in one basket or another. We were the first ones at the Dubin Breast Center to get 3D mammography. And we feel that's really the way to go. It's very little added radiation, there's no injection, and so forth. I think the contrast-enhanced mammography is, again, it is a great tool, and it is better than regular mammograms in picking up cancers, but I don't think it's for everyone because of the contrast, because of the allergic reactions, extravasations, things like that. And I think if you're really, to me the big question is, so who should get it? Well, if you say high-risk people, some of these people actually qualify for MRIs. So are you going to do both? And so I don't think we're at the point yet where contrast-enhanced mammograms replace MRIs for high-risk screening. So yes, maybe there's a group of women with really dense breasts, but who don't qualify based on high risk, for whom contrast-enhanced mammography.
And I think,
yeah.
And I think the other point is, and I agree with you completely, is MRI is not available universally. And everybody does not have access to an MRI, and I think we do know contrast mammography is better than ultrasound. We just got a paper that confirmed that. So,
in terms of added cancer
as
detection.
far as added cancer detection, so I agree completely. It's not an alternative to MRI.
Are you guys doing it
We are
in
not.
your center?
We are not. We're doing lots of MRIs, but Fairfield County and New York City is different than, again, what's going on in other parts of the world where they may not have the appropriate coil to do an MRI appropriately of the breast. And perhaps this is a technology that can be adapted so that, we have additional options for patients throughout the country and the world.
I just had quick question for you, and that is, there's been a lot of sort of contrast and confounding points of view on hormone replacement. And
it's such a
I've just been
huge-
very
I mean-
quite confused about the whole thing as far as like
Yeah.
sort of post-menopause. And
It's the
vis-a-vis
hugest area right now, women's health.
vis-a-vis versus like how it would affect ovarian versus breast cancer.
Yeah.
And did you have
Here's
a,
the
did you
long
have
and the
a-
short
a
of it.
thought on that?
I mean, we could do a whole nother hour on that, but here's the long and the short
Or
of it.
two or three.
Yeah. The long and the short of it is it's an amazing, important tool for women going through menopausal changes. And I think it's really important for women to bridge the gap, to quell symptoms, et cetera, super effective. The only group that I think is really like no-fly zone for hormone replacement therapy is women who've had breast cancer.
But,
If you
but we're getting smarter.
We're getting
right?
smarter
We
about
just
that.
heard
Yeah,
at this
do
same
it,
meeting
right.
that the same proviso that we had with every woman that we talked to about vaginal estrogens with breast
Mm-hmm.
cancer, we probably have overstated the risk and perhaps
Mm-hmm.
that's safe. So we're getting smarter and we're understanding the
Mm-hmm.
pharmacology of these things better. I agree completely at this point. The standard answer is we are not giving hormone replacement therapy to women with breast cancer, but I think we're going to learn a lot more in a very short period of time in
Yeah.
that regard. So.
Yeah.
So, of course, wow, this is such a gift. And if you're like me, you're hanging on every single word from both of you. So thank you, Dr. Port and Dr. Zelkowitz, for taking time away from caring for your patients to share the latest and most up-to-date information with all of us. And speaking of hanging on every word, we all have to say a quick mazel tov to Dr. Zelkowitz and Tammy because their son just got engaged.
Amazing. Amazing.
And Dr. Porter, as we all know, knowledge is power, and we're all leaving here more informed and knowledgeable. But before we leave, we know you're the author of the new generation breast cancer book, How to Navigate Your Diagnosis and Treatment Options and Remain Optimistic I'm so sorry, if I could read my handwriting, it's crazy. Of information overload. Thank you, it's a long.
I think it was.
But one quick thing, so everybody has these right here, this little bag, and it's called the Breast Advice. So can you please talk about this as it relates
I'll
to
give
your
you
book?
5 minutes. So this will be, there's a new book. That book was 2015. It's now 10 years later.
Yep.
And I think the theme today, as Richard mentioned, is there's been so much, thankfully, since. So this is a new book that will come out next year that I'm writing. But for the meantime, there's a really cool website I put up and a Substack. Do you guys all know what Substack is? It's little bite-sized articles on a lot of the topics. It's free. There are cards in the back that there's a QR code. And go on Substack, subscribe, and there'll be articles coming out every 2 or 3 weeks up until the publication of the book next year. The cool part about the book is it's a new way of, I think, delivering information, which is, one of the things that old farts like us have benefited from is it's not only what we teach you guys, but every single person who has been my patient has taught me something and has shared different pearls of wisdom that I've passed on to other patients. And you guys share with each other and support each other. And so this new paradigm is the Breast Advice is where patient experience and doctor expertise meet. Too often, patients share their stories in a vacuum, and you get information from your doctor in a vacuum. And this platform marries these two. So every single chapter is started with a patient story that I think resonates and echoes with a lot of people who've been through it as an opportunity to discuss the newest and the latest medical advances on all of these fronts. So I hope you guys will take a look, and at some point there'll be a book party, maybe up here. So
just wait, a huge thank you to our co-chairs, Trish, Cindy Saul, Diana Atner, for making today possible. We know it takes a village, and you're a team of 3, so thank you. And thank you all for coming and keeping our word connection strong. We really are all grateful, and we thank you from the bottom of our hearts. And lastly, we hope you will join us on October 16th for our evening gala at Mitchell. for 15 years of compassion. And it's going to be fabulous, and more on this in the days upcoming. So thank you all. Our hearts are full. Thank you.